Thanks for joining us, everyone. We are really pleased to be here with Grantmakers in Health today to host this with them, Food is Medicine, and bringing this conversation. I'm just going to take care of a couple of the logistics, and then I'm going to hand it over to Colin. But if you would, please put your name and organization in the chat function, as well as including the Indigenous territories in which you're joining us from today. And if you have questions along the way, please put those in the chat box as well. And Colin and I will keep track of those, and we'll make sure that Diana has those when we get to the Q&A portion of the discussion today. But really happy to have you all, and thanks so much. And I'm going to hand it over to Colin.
Well, great. Well, thank you, Tracy. As always, it is terrific to be able to partner with Sustainable Ag and Food Systems Funders on another program like this. So I'm Colin Peckrin. I'm a program director here at Grantmakers in Health, and this is a topic that we've been really excited to have some additional programming on at Grantmakers in Health, and are really pleased that we can be doing this thanks to some support from the Kresge Foundation. This is going to be one policy call amongst a series that we'll be doing over the next year or so. But just know that this is a space that a lot of health foundations are very excited about and are doing a lot to drive, as you'll hear from a couple of our speakers today. And I'm just thrilled that you all are here, and I'm looking forward to the discussion we'll be having today. But with that, I want to hand it over to the people you're here to hear from. And so, Diana, if you want to take things away, I will step back.
Hi, everyone. Diana Johnson with the Rockefeller Foundation. I'm thrilled to join you today and talk about a topic that is very close to me. I oversee our Food is Medicine portfolio for our Global Food Initiative focused in the US. And I'll just kick us off by starting with a few slides to give a little bit of context on what we are talking about today, and then I'll introduce our panelists. So first, the Rockefeller Foundation, we have a good food strategy that informs our work across the globe. We have global, Africa, and US portfolios, and they're all focused on promoting a good food system, that is food that is nourishing, regenerative, and equitably produced and distributed. And our good food strategy has three main pillars. The first is data and science innovation. We have good food policy as a second pillar, and we also have a good food public purchasing pillar. And today, we're honed in on, under our good food policies pillar, our food is medicine work. And I just want to take a moment to say that food is medicine is defined in many ways, and we acknowledge that this has been recognized in various cultures and communities around the world long before we were talking about it in this context. But for the purposes of this discussion, we are talking about food is medicine interventions that are specifically taking place within a healthcare system. And they generally serve purposes of increasing access to healthier foods in support of health and other health outcomes. And so this pyramid is just a quick view of some of the programs we'll talk about and interventions we'll talk about today. This was developed by the Center for Health Law and Policy Innovation at Harvard. And we're really focused on those top three parts of this pyramid, which are medically tailored meals, medically tailored groceries and food, or produce prescription programs, which are all intended to improve patient health outcomes, patient satisfaction, in some cases reduce the cost of healthcare, and other outcomes that some of our panelists will speak to today. And in terms of the Rockefeller Foundation's role in this, we certainly have a lofty policy goal to and hope that in 10 years, food is medicine programs will be widely available to Americans in Medicare and Medicaid. And we know there are many steps to get there. Generally, we frame our grant making and strategy for food is medicine under these three buckets on the left. We support groups that are generating better evidence to show that there is some return on investment and there are better outcomes in using food as medicine programs. And so we have some research grants to the organizations listed in this slide. We also support several organizations to support better policy. And by that, we mean supporting at the federal and state levels opportunities to both test and scale food as medicine programs using different waivers and different pathways that are available through CMS. And then there are also some regulatory pathways that can be explored, including performance measures and many other intricacies of the healthcare system that can be advocated for to scale these programs. And lastly, we support grantees in the better infrastructure bucket, which we call this space is to support direct implementation of food as medicine programs. And we have listed some partners here that do that in close partnership with healthcare systems as nonprofits. And they also, a few of them take a very deep equity lens in working very closely with their communities in community-directed programming. We have the VA listed here. They're not a grantee. However, they're a large healthcare system and provider that we are in close conversations with to scale some of these programs with as well. And we are happy to announce that we will have other grantees that are going to join us. We're currently in the due diligence process, and we'll be able to share that at another time. So with that, I would like to now introduce our speakers. I think let's get started first with Brent Ling, who's the Director of External Affairs at Wholesome Wave. Hi, Brent. And we have Mary Davis, the Director of Healthy Food at Blue Cross Blue Shield of North Carolina Foundation. Hi, Mary.
Hello, everyone.
And lastly, she may be on the line. We have Maria Elena Rodriguez, who is the Director of Research and Community Partnerships at DAISA Enterprises. And Maria Elena currently is in Puerto Rico, where there is a lot of devastation from the hurricane that just passed. She may or may not join us by the phone. So if you are there, Maria Elena, say hello. And if not, we'll get started, and we have some information from her we can share with you all today.
Hi, everyone. Can you hear me okay?
We can hear you.
Great. I'm glad to be here, even though I can't see everyone, but thanks for yeah, I'm glad to be here.
Thank you for joining us. And we'll actually ask you to answer our questions first in case we lose you on the line. So the first question we want to ask our panelists today is to tell us from your perspective, what food is medicine to you, what your role in this space is, and some examples of how and what you're doing under food is medicine. So with that, we'll start with you, Maria Elena.
Sure. Thank you, Diana. And please let me know if I'm running long on time. Feel free to cut me off. I want to make sure that there's time for everyone. But it's a pleasure to join the panel today, and thank you for that introduction. And yes, I just want to say that it is a bit difficult to kind of connect today, given the current devastation that the island of Puerto Rico is experiencing from Hurricane Fiona. And I won't spend too much time on that, but I want to recognize that that's where I'm calling in from today, and that influences just my ability to be here. And I thank everyone for your patience in probably a subpar panel participation, but I'm here and I'm excited to contribute what I can. So my name is Maria Elena. As Diana mentioned, my pronouns are she and her. I am the Director of Research and Community Partnerships at DAISA. I am based in Luquillo, Puerto Rico, which is in the northeast corner of the island. DAISA is a national team of equity-focused consultants. We work at the intersection of food, culture, and health, and we partner with social enterprises, nonprofits, community leaders, policymakers, funders to support the realization of equitable food systems in vibrant communities. We are a remote team spanning across many different states in the country and also Puerto Rico. And we have dug into work in the food as medicine space in a number of different ways. I'll mention first that we are technical assistance provider of the Gus Smith Nutrition Incentive Hub for produce prescription programs. And we also have a long-standing partnership with Wholesome Wave, and reaching back a number of different years. But beginning at least in 2020, DAISA was commissioned by Wholesome Wave with funding from Walmart to start in developing a body of work around the produce prescription model and field. And as Diana mentioned, I recognize that the food is medicine interventions can span can look in many different ways and encompass other models. We've focused a lot on the produce prescription model, so that's kind of what I can speak to. But as a part of this body of work, DAISA, along with Wholesome Wave and the leadership of Ben Perkins, we've assisted in developing an equity framework for produce prescription programs. We have also conducted 3 different research field scans, one of which is a field scan looking at emerging technology solutions in the field, which is forthcoming, has not been yet released. And we also, in 2020, we began conducting research looking at existing produce prescription programs across the country over the last decade. We were really looking to understand the growth of the field, including where these programs were established, how they operate, their challenges, their best practices. This report was published in April 2021. It's called Produce Prescription Programs, the U.S. Field Scan Report 2010 to 2020, and it included a number of recommendations for the field. One of those recommendations was to further explore the experiences of organizations and program operators in the produce prescription field who identify as Black, Indigenous, and people of color, BIPOC. And we had this developing hypothesis that there was a number of these BIPOC programs that were really embedded in local community, but potentially lacking structural advantage of white-led programs and experiencing significant barriers to program success and even recognition in the field. We also knew anecdotally from a number of these programs that they were excelling in really building deep community trust and centering cultural food traditions. And so Wholesome Wave partnered again with DAISA in 2021. We embarked on this research, which was finalized in June. Along with partners at the Yale School of Public Health and with Wholesome Wave, we're in the process of submitting the report for publication as a peer-reviewed journal article, which we're really excited about because that will really contribute to addressing a bit of the lack of academic research that's based in BIPOC perspectives and programs in the food as medicine field. And so what I share here today is really based in those learnings. It's based in the conversations that I've had with many, many different program operators, from extensive interviews, focus group conversations, and also in DAISA's role as technical assistance provider for Gus Smith. Sorry, I've got some dogs back barking in the background. I'll pause there.
Thank you so much, Maria Elena. Brent, same question.
All right, what is food as medicine to me and and my story in this space? First of all, thank you for the invitation to be here. It's great to talk with this audience. Many of you are familiar with Wholesome Wave. The organization's been around for 15 years. So I'm just super thrilled to be here. It was first explained to me by many people's favorite bureaucrat. He said that essentially healthcare stands to gain the most from changing diets for the better. And therefore they should be buying healthy food for people who need it. And I have to admit right off the bat that I said right to Gus Schumacher's face that did not seem at all realistic. And today that is my job, is simply to advance that agenda that he pitched to me not all that long ago. And really this kind of visioning takes two very simple things, and part of the produce prescription model is the beauty of the model is its simplicity. Gus and Michelle and Wholesome Wave's ability to commit and dedicate to approaching people in their own communities and engaging them with empathy, humility, and respect. And then second is a design of an intervention that puts dignity at the center, and in our case, empowerment over health and patient choice over the produce that they purchase. It's this foundation that has led Wholesome Wave's efforts for 15 years. And we really take interesting ideas, we invest in them, we draw out various learnings from various different perspectives, and then we commit to making everyone learn everything that we learned as publicly accessible as possible. There are dozens of produce prescription programs and staff incentive programs out there. in the country that were started by somebody picking up a Wholesome Wave toolkit. And so now we're taking that understanding and investing in advancing, as Maria Elena mentioned, we're investing in learning about fidelity, equity, and dignity in our programs. And we're hopefully doing this in a way that leads to all the other programs around the country investing a little bit more and advancing their programs to be a little bit more. These require specific concentrated investments. And what happens so often is that everybody tries to feed as many people as possible with their grant or program, and often cut corners. And there's spaces where that just has real major consequences, and we're making sure to learn that, to make it official by putting it in peer review and sharing that. So at Wholesome Wave, I lead our external affairs, where I engage funders, grocers, patients, doctors, and researchers to help develop and execute the leading innovations in produce prescriptions now. As I lead our policy advocacy agenda, our top priority is to embed the produce prescription model into standard healthcare practice. We truly envision a day where a doctor diagnoses a patient as being at risk of a diet-related disease and also notes some kind of a personal financial barrier to accomplishing the dietary change that is needed. And just like that doctor today can prescribe a medication, send it to the pharmacy of the patient's preference, including being delivered to their door at sometimes, and all of that visit and subsequent medication is all covered by the insurance plan. We believe one day that doctors will be able to prescribe a food prescription and produce prescription in exactly the same way. So we also host and staff a coalition called the National Produce Prescription Collaborative that Diana mentioned, where many, if not all, of the nonprofits that this community has funded to execute some produce prescription and other food as medicine programs. That community has come together, each chipping in their particular learnings or expertise to act as a national advocacy voice for this model and its use as a treatment and prevention of diet-related disease within healthcare. We've all experienced that moment where your grant ends and you have to tell the patient, we no longer can offer you the program. You knew it was going to be 10 months or a year of signing up at the beginning, of course. No hard feelings, but that is a very difficult thing to do for a patient who still needs it. And it's inevitable in the grant funding model. If we can be successful in advancing it in a healthcare model, that problem goes away. The patient receives the program as long as their doctor believes that it's necessary, they want it, and the insurance is willing to pay for it, and doesn't necessarily have this arbitrary deadline that we often work with. So now Wholesome Wave has lots of different things that we advocate for outside of produce prescriptions. Anything that is successful at getting healthy food in the hands of people for whom price is a barrier to entry. We are supportive of lots of different programs in the Farm Bill and lots of different anti-hunger programs as well. And when we talk about healthy food, we really focus on fresh fruits and vegetables. When it comes to food as medicine policy, produce prescriptions are just one of many interventions that are working to develop in a spectrum. If you're looking at Diana's slides, you notice that there are several different pieces of what is now described as a pyramid. There are different parts of it. So for some people, a produce prescription is perfect. Others will need a food beyond produce to treat the condition that they're working on. Others will need a eat and eat medically tailored meal to help them recover from a procedure that has them down flat. Whatever is needed, the same healthcare and healthcare policy infrastructure is needed so that we have, it's needed to execute and deliver on the prescription model as in the way that I kind of presented earlier. We have no interest in simply advancing produce prescription policy and advocacy, but rather advancing it in a way that patients can get the type of food that helps them the most at little or no out-of-pocket costs. So with that, I just want to leave with one other plug, and that is our coalition that I mentioned previously. The National Produce Prescription Collaborative is having an all-day in-person event next week in DC, where you could meet almost our entire coalition. You can hear the weedy detail that goes behind everything that we're going to talk about today, and hear a constituency response to the White House Conference on Hunger, Nutrition, and Health, as it'll take place the day after. So we have some space set aside for funders, and if any of you are interested, I'm just going to ask you to please email me. I'll throw my email in the chat. It would be great to see you there. And I'll leave it at that.
Thanks, Brent. And over to you, Mary.
Thanks so much, Deanna. Last but not least, right? So the Blue Cross North Carolina Foundation, so we're a state-based funder, and our food is medicine work really lives at the intersection of our healthy food focus area and also our healthy communities focus area. And that's significant because what food as medicine means to us, or what it is to us, it's about healthcare and community-based organizations coming together in new and different ways to improve health and address food security. So our belief that we think is somewhat unique is that CBOs, these community-based organizations, are really critical partners in the food as medicine movement, given their deep and long-standing experience in this space and addressing social needs in their communities. And we also believe that food as medicine can support the local food system, which means that in addition to improving community health, for us, food as medicine is also an opportunity to improve community wealth in North Carolina by engaging and supporting local growers in this work. And that's important for rural states like North Carolina that really are at the bottom of the list for food security, but have these deep agricultural traditions and long and productive growing seasons. So in terms of an example, so we have a food as medicine grantee in rural Western North Carolina, the Hunger and Health Coalition, and they are partnering with their regional health system to screen every patient for food insecurity in the outpatient and the inpatient settings. And so during COVID, they developed a relationship with a local farm who had lost all of their restaurant markets and hospitality markets, right? And now, you know, a few years into the pandemic, because it certainly isn't over, the Hunger and Health Coalition is their biggest purchaser of fresh food, right? And the clients are really raving about the lettuce and the peppers, right? So food as medicine has helped keep this farm running, an important farm that's important to the community, and has provided patients with fresh, healthy food. So that's just like one example of our 10 incredible community-based partners in this space. They are partnering with various healthcare providers, from insurers, health systems, community health centers, free clinics, etc. And our investments are focused on strengthening and spreading their work across North Carolina and really beyond. And we're doing this through direct grants that are focused on capacity building and infrastructure. We're also supporting a community of practice and technical assistance to help them come together, to learn from one another, to support one another, and to get the technical assistance they need. And then also some strategic communications to help elevate the good work that they are doing and really bring attention to food as medicine as a solution for better health and for better food insecurity. And all of that is based on a scan that we did late last year. That was a scan of everything that was going on in North Carolina in the food as medicine space. And I'll drop a link to that scan in the chat. And that really helped inform what we needed to do in North Carolina to take this work to the next level. Pass it back to you, Fiona.
Thanks, Mary. So one of the objectives of this session is to also talk about areas of action and opportunities for policy in the space. So the next question to all of you is, where are the policy opportunities for food as medicine right now? What are you all seeing from where you sit? And I will pass it first to Maria Elena if she's still on the line.
Hey there, still here.
Great.
Sure. So I can talk a bit about this. I feel like what I have to share will probably also build upon what I imagine Brent is going to speak to. But so from my perspective, the research really shows that there are still some grave disparities in access to policy change, voiced and levers. The BIPOC-led and immersed organizations that are working in food as medicine or improved prescription are under-resourced in their capacity to be present at policy change coalitions, and their program innovations and advances really go under-recognized in state and national policy conversations. There are some folks that I have spoken to in these interviews that are very active in their local and state policy advocacy for food as medicine, but it's not the case for everyone as far as having capacity and funding to be at those conversations. Their funding is, often limited to programmatic short-term funding, and they're sometimes just scrambling to pull together resources to keep the program going, much less have the capacity to work on advocacy. But As I imagine others on the panel are going to speak to, there is a really exciting opportunity to embed produce prescription and food as medicine initiatives into Medicaid and Medicare, which would, across the board increase access to healthy foods for all. And waivers are allowing states to work with some of these innovative produce prescription programs that are driven by community-based organizations, and allowing for really exciting experiments and building a large base of data to show how these initiatives are improving access to healthy food and reducing chronic disease. While produce prescription and food as medicine is now being thought of as a health intervention, and there is this kind of great policy drive to integrate further into healthcare practice, the research also shows that BIPOC communities are usually thinking of broader systems and holistic community impacts. Many times in their models, these programs integrate BIPOC-owned community retailers, BIPOC farmers that are producing cultural foods, culturally based nutrition education and celebration. So these broader food, social, and economic system integrations encourage social determinants of health impacts and should also be considered as part of policy. But the opportunity that we want you to hear the loudest right now, and that is the most immediate and powerful, is really to use your funding to make sure that program leaders that are from Black, Latino, Indigenous, Asian organizations and communities are supported in equally accessing policy advocacy opportunities, and that they are able to represent their communities inclusively. That there's funding available and that it's made accessible for these community leaders to also be at the table.
Great, thank you, Maria Elena, and thanks for highlighting that point of the inclusion of BIPOC leadership in policy discussions. I'm going to pass it to Mary this time and then to Brent.
Thank you. So, thanks to Rockefeller and Wholesome Wave and DAISA for working at the national levels. Very excited to, hopefully that will all come to fruition and that the models that are happening in North Carolina can help inform those policy changes. So in North Carolina, in terms of, because we're a state-based funder, we do not invest in national policy change work, except to inform it through model development. But in North Carolina, we have a Medicaid 1115 waiver that is supporting, and I imagine, Brent, that you're going to talk a lot more about this. So I won't give a lot of details there, but we have a waiver that's supporting food as medicine interventions, paying for them in 3 different regions in our state through a healthy, it's called a Healthy Opportunities Pilot here in North Carolina. But this is a Medicaid waiver that is paying for food as medicine for certain Medicaid patients. So this is a massive undertaking and very much out of our hands. But what we see as our role in philanthropy is to really help boost the chances for a successful pilot. I mean, this is really a re-envisioning of health and healthcare delivery. So it is not for the faint of heart, I will say. Happy to talk more about that in the discussion part of this webinar. But about half of our healthy food prescription grantees, that's what we call them, healthy food prescription grantees, because they're doing so much. They're doing medically tailored meals, they're doing medically tailored food boxes, they're doing fresh food boxes, they're doing all sorts of different things in that space. It's not as clear cut as the nice pyramid that Deanna showed earlier in our presentation. They do a little bit of everything. So because half of our grantees are really involved in this pilot, this waiver opportunity, because they're part of our investment will provide extra capacity building funding and technical assistance to help support their efforts, right? So they're using that for things like developing, interfacing with new technology and billing platforms, things that they've never even thought of before, right? Or meeting healthcare's extremely challenging privacy and security requirements, or shoring up staffing and infrastructure needs, these are especially critical in our rural communities. So we're hoping that by including those folks who are part of the waiver among our grantees, that they'll get a little extra boost, hopefully leading to a successful waiver implementation in North Carolina. in terms of another policy opportunity that we see at the state level is that there's a significant, like everywhere, right? There's a significant amount of ARPA, American Rescue Plan dollars that are coming into our counties and into our municipalities, right? And we think that this is a great opportunity to increase investments in creating a stronger local food system and addressing food security and having those local governments really supporting these efforts. So what we're doing there is it kind of piggybacks on to what Maria Elena was saying, is that we're providing advocacy training and support for community-based organizations to advocate for these funds to go to these efforts. So this isn't specific to food as medicine, but includes food as medicine investments. For example, right now, what we just heard is that one of our counties, which is one of the hungriest counties in North Carolina, just approved $850,000 for a food security plan and implementation, which is really unprecedented for a local investment in this across North Carolina. So those are some of the policy opportunities that I see at the state level, but I'm going to turn over to Brent, who is a lot smarter about these things.
Go ahead, Brent.
Thanks, Mary. That's quite a compliment. I'm not sure I'll live up to it, but I think it's helpful to start with presenting the policy platform that we are pursuing at the National Produce Prescription Collaborative. I'm going to try to share my screen and hopefully you won't see my email. But this should look like the National Produce Prescription Collaborative webpage. Am I seeing that? Okay, great. So this is our policy platform that we shared with the White House and took a good 6 months to come up with. Each of these got a page in the White House comment or more, but it's simply as a lot of stuff that has been already mentioned, but we're talking about advancing Medicaid pathways for coverage, same with Medicare Advantage, same with traditional Medicare. We're also advancing for demonstration projects at comprehensive total cost of care systems like the Veterans Health Administration and Indian Health Service. We're working hard to advance quality metrics so that those who are in value-based care payment arrangements can start paying for outcomes, so that they can start paying providers when they do a better job about getting their patients off of medication for diabetes or preventing it in the first place. And then we also are aiming to revise IRS nonprofit hospital community benefit reporting standards because a lot of those hospitals are putting out reports after reports after reports that say food and access to healthy food is the #1 important issue, but they don't invest a lot in delivering that. So we also work on funding federal research, and the bottom, but probably the most important, is the healthcare coding infrastructure. If we're successful with all the policy asks that we want in the world, none of it moves unless there's a medical code for a doctor to issue the prescription, the bill for the time, and then for a plan to reimburse the payment for that at the end of the line with the grocery store. So I figured I would share that to start with, because as I'm talking about opportunities and bills that are moving is commonly used as a term around this. There are a lot of there are a lot, but there's a commonality between them, and I'll get to this in a second. So we're about 2 years since the official forming of the coalition of the NPPC and the publication of our consensus definition of what a produce prescription is and what our mission was. So in those last 2 years, the best policy successes have come in Medicare Advantage, in Medicaid, Indian Health Service, and Veterans Health Administration in the form of appropriations bills. Essentially, everywhere there can be action without Congress having to come together. It is no secret that pretty much the only comprehensive consensus bills anymore are in times of absolute emergency, if you're lucky. But however, appropriations bills do need to be passed every once in a while, and so we've had some success moving projects in those bills. So generally, what we're talking about is state Medicaid plans and Medicaid waivers. North Carolina was a perfect example. Medicare Advantage, where Medicare Advantage plans have been afforded a ton of opportunity to invest in produce prescriptions and other types of food as medicine interventions to help treat those who are at very, very high need. They don't have that same opportunity right now to prevent those patients from becoming in high need. And where that can be addressed is in the form of CMS guidance. So CMS guidance letters, when they write guidance to their plans, that has a lot of implications and can oftentimes be even more powerful than a congressional action in healthcare. So CMS guidance is kind of the third pillar where I believe that there is opportunity and where we're seeing things move. I mentioned the appropriations bills for demonstration of that Indian Health Service and Veterans Health Administration. Perhaps there has been an interest from Congress in pushing those, and I do believe that perhaps there are other niche areas of HHS that could be candidates for appropriated pilots as well. And then another moving bill sort of action is the White House Conference on Hunger, Nutrition, and Health. It is happening next week. And the White House, in that action and the subsequent plan that they plan to execute over the next few years, presidential directives, executive orders to various branches of HHS that could advance the food as medicine agenda there as well. I'll again remind everybody that we're having an event next week, the day after the conference. Finally, there's a couple other areas to think about. The Farm Bill. The Farm Bill currently has funding for produce prescription projects. While we would need 1,000 Farm Bill projects like this to equal the potential for one state's Medicaid waiver, it is still important to seeding this model in healthcare systems and clinics across the country, as well as developing the infrastructure to prescribe and track and fill the fruit and vegetable prescriptions. There's also grants that are being developed in certain states where the state's Department of Human Services, the Department of Health will put out a grant for exploring this at some of their targeted hospitals for certain targeted patients. So that's the summary of the policy opportunities that I see and pieces that are moving like right now in the next 6 months.
Thanks, Brent. And we have one more question for everyone to answer, and then we'll get into the Q&A session, which maybe perhaps a lot of the funders are eager to get into. And I also just want to acknowledge that there's a lot of complexities here because this is an area of work that touches on healthcare and food. And if you're a healthcare funder, understanding the full complexities of the food system and value chain might not come immediately. If you're a food and ag funder, understanding healthcare policy can be quite complex. And then there's some folks who live right in the middle, including some of the panelists, and some funders who are trying to put it all together. I just want to acknowledge that it is quite a lot to understand. So with that in mind, to our panelists, can you tell us where there are currently some gaps and maybe some opportunities for funding food as medicine interventions, programs, and policy advocacy? What would your recommendations be to funders on the call? And again, I'm going to pass it to Maria Elena if she's here, and then we'll go to Brent and Mary.
Sure, thanks. So I am going to share some recommendations that come directly from the forthcoming report that I mentioned, the BIPOC Produce Prescription Program Operator report that focuses on experiences of those BIPOC program operators. And when the whole article is published, Wholesome Wave, DAISA will be circulating it, and definitely encourage you to read the full report. There's a lot of richness in it about BIPOC program innovations and challenges, but I want to lift up these specific recommendations. And I want to also mention that they are applicable across many, not all funding programs. They're not necessarily unique to food as medicine, but they came directly from interviews and focus groups as a part of this research. And so that's why I want to bring attention to them here. And in the report, we break out the recommendations kind of geared towards different whether you're a funder or you're a partner community organization or you're a policy advocate. But one recommendation that was across the board for every type of partner was to commit to true solidarity versus performative allyship in decolonization and anti-racism work. There's a lot of focus right now on DEI and equity training, but the encouragement is to go beyond that, to really do the deeper personal and interpersonal work, to put those principles into practice, to shift the actions and the culture of your organization. And then specifically recommendations for those who are funders or in philanthropy. And so again, some of these are going to sound familiar, but this is what was shared with me, is to really reevaluate grant application processes and reduce barriers and complexity for smaller programs that don't have dedicated grant writing staff. Taking direction from community organizations on the important stories and data to lift up through reporting and evaluation as much as possible, minimizing bureaucratic and complex reporting that doesn't serve the community specifically. Mary mentioned earlier strategic communication. That's very important. Funding the creation of case studies and other communications that can increase the visibility of community organizations as BIPOC voices and their innovations in the field. And taking direction from BIPOC organizations and creating guidelines around what foods can be purchased by program participants. There are some programs out there that have, some funding programs that have restrictions on certain foods that are culturally important foods. So removing any restrictions on these cultural staple foods or engaging in conversation with organizations that you may be funding to ensure that the food that they are able to purchase through the funding meets their cultural needs. And then, there is a call to buy into the larger community vision of change and support the agency of the BIPOC leaders in determining how to get there. Committing to longer term, unrestricted funding whenever possible, which can really help to minimize administrative burdens on smaller BIPOC organizations. And in doing just that, the recommendation is really to seek out and proactively build relationships with these BIPOC-led organizations to learn about their work and to understand how you can best support them in directly funding their work. And my biggest recommendation, my biggest takeaway is really to commit to actually shifting power and centering BIPOC voices. So unfortunately, this panel is a clear example. There is not one practitioner, grantee, on-the-ground community member on this panel today, after numerous requests to include them. I think everyone on the panel today, we bring very important perspectives and knowledge, but as for what these concepts that we're talking about look like on the ground, we are speaking on their behalf. We have data to point to. There's, like I said, many interviews that I have conducted that give me a great amount of data to point to that I can do a decent job of that. But the fact remains that BIPOC practitioners continue to be left out of opportunities like this to speak directly to funders. And that's just not acceptable. So if folks are committed to equity, BIPOC community voices need to be centered and should not be an add-on or an afterthought.
Thank you, Maria Elena. Thank you. Can I pass it to Brent?
As Maria Elena mentioned at the beginning, we're in long-time partnership with Wholesome and DAISA, and I've been lucky to work with Maria Elena and her team and learn from them and this work together over the last year. And I definitely support everything that she just mentioned. There are a lot of amazing programs out there, and every once in a while a program is able to take the time to produce a nice report or even get mentioned in some local press. I'm lucky enough to make this a full-time job for myself to push this out. But if you give a talented nonprofit that's really doing community service work a grant, they're going to do absolutely everything they can to make sure that every penny of that goes to paying for food for the patients that is needed in this case, to directly serve the community. And what gets missed out is what Maria Elena mentioned earlier, is the dissemination tactics that we know are needed. That's why we're all on this webinar, is community learning and learning from other people across the country. A lot of what my job is truly finding an interesting article or a study from a small town in Indiana and making sure that everybody who that matters to in DC that can expand upon that work and can re-resource that team and that community hears about it and knows about what it means. So the dissemination is key, and I think that there's probably an opportunity for grant makers to insist that there is a deep strategic plan for dissemination. I think there's certainly place to invest in maximize the impact on your community, absolutely. But there are also areas where dissemination is really important because it can grow what you've invested in from utilization by other people. Every time I've heard somebody present on a food as medicine model in real life, I've inevitably seen somebody in the audience turn to their neighbor and say, I can absolutely do that, or we should be doing that. And then they go back home and start working on how to get it funded and how to make it happen in their community. So dissemination is really important, and a lot of your investments, I believe you aim to have reach beyond your particular project. So dissemination is key. Those resources are not always delivered. They're not always required. They don't always need to be, but in certain circumstances, if you expect it, you need to provide the resources to be able for the implementer to be able to do so. We also need studies that speak to healthcare audience. We need studies that include 300 patients with a data agreement for a case control group, all under the same payer, that are getting at least $50 a month in fruits and vegetables. And ideally, this analysis is conducted by a firm that has legitimacy within the healthcare community. We rarely acknowledge the utilization study of RAND from many, many years ago now that essentially said if you offer more coverage, then patients overutilize healthcare. All those years ago, it has influenced foundational beliefs about our healthcare in our country that has shaped health policy decisions and had immense consequences. We need another RAND type of study for produce prescriptions and really food as medicine comprehensively. And then finally, I want to point out that if we are very talented and very lucky and we get health plans to cover the cost or most of the cost for healthy food, that is all they will cover. The plans will never pay administrative fees. They will never pay transaction processing fees. They will never pay for expensive peer-reviewed IRB study out of the capitation rate, which is what our aim is, or the medical loss ratio. So infrastructure is really important at this stage. There are a lot of creative ways, some of them Mary mentioned already, to invest in the infrastructure that will have dividends. As states like North Carolina start paying for the food, you need to be able to deliver on that, and that requires infrastructure. So if I'm going to use a random state here, Oklahoma, Medicaid decided tomorrow we're going to reimburse for all the food in the world, they wouldn't necessarily be able to execute on that because they don't have the infrastructure built out. So I would encourage you to consider those types of investments in your programs going forward, because I believe, and I think there's an industry perspective that shares this belief too, that we're going down this path. And I think those infrastructure investments will have dividends.
Great. And Mary, last but not least.
Thanks, Elena and Brent, for such good suggestions already. I'm looking through my notes and wondering like what else I have to add. I mean, I'll just like put an exclamation point on infrastructure, flexible dollars for infrastructure, right? So flexibility, underlined, capacity dollars for these nonprofits to do this work, no matter what policies are put in place and how amazing they are, or what insurer plans to pay for this. It's just such a culture change for healthcare to partner with CBOs to do this work. And it requires a lot of time and effort to make those relationships and partnerships work, to work towards equity in those relationships. There's a lot of technical barriers just to contracting that can get in the way of even the most well-intentioned work. So yes to doing that. In like an example, Reinvestment Partners, which is a local Durham-based nonprofit, came to us a few years ago because they were going for a GusNIP grant and they needed the matching dollars, because you know how the federal grants, they always need the matching dollars, which again, I'll say all the matching dollar stuff that the feds require, do that stuff. Like we need to do that stuff to leverage those dollars in our states. So they came to us and they said, okay, well, we can only pay for food. We can't pay for an admin cost, but like, we can't do this without admin. Can you help support us? And we're like, okay, we're getting excited about the social determinants of health space. We're going to support you, and we're going to give you some extra dollars because we do think we think you could be a leader on social determinants in our state. So we bumped up the budget here from what they even asked, and now a handful of years later, they are the largest. My understanding is that they are the largest produce prescription program in the country. They're serving all 100 counties. They have, because of that extra space in their budget, they were able to advocate and secure additional funds from our General Assembly, which, if you know North Carolina, that's interesting, to support their efforts. And they're informing policy at really a local level. They are really a whisperer to DHHS in the implementation of our waiver and at a national level. So it's worth it. Yes, elevating these stories, supporting comms, but also recognizing, like to Brent's point, these folks are busy, you know, like you want to give them communications dollars, but can you hire someone to do the comms work for them and to support their efforts? And can you use your platform to help elevate their stories? That's another thing to consider. And then, yeah, conspiring for the success of these publicly funded efforts, right? So you got the GovSNP match, and you have waiver implementation, you have these new referral platforms that allow healthcare to refer to nonprofits, all that stuff. There is not enough money to support reinventing healthcare, and philanthropy is going to have to play a role in all of that. Maybe I'll leave it at that, but thanks for letting me chime in.
Thanks so much, Mary. And now we're going to transition to our Q&A and discussion, and we have some questions in the chat. I'll start with what I see. And this is for everyone. This is from Margarita Gonzalez. Can you talk about how your organizations balance the immediate relief needs that are so prominent and the need for advocacy around long-term change? Who'd like to take that start?
That's I can jump in quickly. Like that's something that we struggle with, just even internally as staff, right? And I think what we have determined is that, you know, philanthropy, you know, has the luxury of focusing on the long term for more transformational change. So that's how we view it at the Blue Cross North Carolina Foundation, that it's really incumbent on us to take the long-term view and make those investments and focus on advocacy, or else we will just continue the cycle, the Band-Aid cycle, the charity cycle.
Thanks, Mary. Brent?
First of all, you know, we do sometimes meet funders who are looking to maximize their impact, and we have places that we recommend. There are there's probably plenty more, right? I'm not here to endorse anybody, but like give $1 to Feeding America, give $1 to World Control Kitchen if you're looking at immediate response to urgent need at the moment, because there is that urgent need at the moment and it needs to be met. Wholesome Wave, since its beginning, was founded by a former USDA secretary and a chef, and it was a 3-person shop with an idea. And they found their niche in advancing some of these models and trying to get policy to take them up, and having, you know, the way for a team of 5 to have an impact like Feeding America does is to change policy. And so that's kind of what Wholesome Wave is rooted in. And so we don't ever take dollars and promise that we're the best ones to get it into the field right away. We make sure that the people who are experts at that do that. And that's kind of how we approach that balance. We're very much committed to the long term, and it's the only way we can have a real impact at a team of our size.
Thank you. Maria Elena, anything to add?
Yeah, I think both of those answers super helpful. I would only back them up and say that, you know, the focus on longer term general operational funding. I mean, there are many organizations that I spoke with on the ground who are doing a fantastic job at meeting their community's immediate needs, right? And then there are a few of those who have found the resources and adjusted their internal capacity to also participate in statewide policy advocacy boards or, you know, other efforts. But that's not the norm. I would say a lot across the board, when I would ask folks, you know, okay, what is your current involvement in policy advocacy? How would you like to be involved in? I mean, there was always the response was like, yeah, we just don't have the capacity. We don't have the people power. There is a huge focus on the immediate need and getting, you know, programs up and running and functioning, and maybe even scaling and expanding them, but making that next leap to like, okay, we have capacity on our team to really engage in bigger picture systems change, like that is not, it hasn't always been the case. So, I mean, all I would just shine a light on it, continue is to, you know, longer term, like releasing the burden off of organizations to constantly be in this yearly cycle of, you know, seeking funding every single year to kind of the hamster wheel of current programming, releasing that burden a little bit such that people have the people power and the capacity to expand beyond that immediate need.
Thank you. And I'll quickly add from my perspective that just to reinforce that point, that many of the organizations that are doing this work and innovating in this space actually do both, right? They are both doing immediate relief and doing longer term work. And so that's just a reinforcing point that, you know, supporting with general operating grants or other forms of funding that are longer term can be extremely supportive in both spaces at the same time. I'm going to go to the next question, which is from Elizabeth Berger from Sunflower Foundation in Kansas. Two questions, actually. The first regarding policy. She's curious to hear thoughts on engaging state Medicaid agencies on this topic when there is not a big appetite for innovation, pun intended. Thoughts on the best way to leverage any interest expressed by MCOs around food as medicine work. That's the first. Why don't we start with that first part of the question?
I'll jump in with some experience at the state level. When there is an agency that doesn't want to move, it can be sensed right away. And I would suggest stop trying immediately and focus your efforts in other places. The two pathways that will influence the Medicaid agency the most are the MCOs, but they're number two. So when you find a champion in a health plan that wants to push this along, when they tell the state that they want to do this type of work, the state will let them and let them innovate, and we'll work with them on the policy framework to allow them to innovate for the most part. But their boss is the number one best place to go, the governor. And they have a mandate usually to follow what the governor directs them to do. And that advocacy can be done grassroots in all different ways, inviting the governor or gubernatorial candidates who are rumored to be running or are running to your programs, making sure that they know what the programs are doing and what they're capable of, is a great way to get on the Medicaid agenda when the Medicaid agency is not interested in some of these innovations. Just a couple ideas. I would steer clear from legislating. I think almost across the board, there's a big tension between CMS and state Medicaid agencies and what the legislatures try to do, and legislatures respect that. They rarely say you have to cover this and you can't cover that in your health plans. And that's, I don't know exactly the root, it's tradition sort of, but I would go with the governor and the MCOs.
Yeah, and in terms of the MCOs, I mean, I would say just the experience of, so the foundation, Blue Cross North Carolina Foundation, is separate from the health plan. They are our living donor, but we are separate organizations. So in terms of our ability to spark their interest on various topics, it varies. And then what has been helpful in this space is to kind of show them, right? To lift up organizations that are doing the work and create even, site visits, we have found have been particularly helpful. So those are opportunities there. And you mentioned about, the outcomes. I feel like there's so many studies, and there is an Aspen Institute report that kind of is a meta-analysis of impact of food as medicine programs. And I think that is very helpful. That just kind of shows across the board, there are very positive outcomes. And then in terms of, you need this rural, you need the data on the very rural areas. I mean, I just wonder, like, maybe they're already doing that, and can you, well, I mean, you could provide, research support also, but then also just connecting that work with the folks who are interested in it. That's helpful.
Thank you. And just in case anyone is not familiar with the terminology, CMS stands for Center for Medicare and Medicaid Services. MCO is Managed Care Organizations. Keep me honest here, Brent and Mary, and Maria Elena, if I got that wrong. Maria Elena, did you have anything to add to this question?
No, I didn't. Those were fantastic answers. Thanks.
I'll go to the second part in that case, which is on logistics. So in order to engage policymakers, we need outcomes. In order to get outcomes, we need to figure out how to implement food as medicine strategies in very low food access areas, especially rural. Any thoughts, examples would be helpful. So I think this question is, are there examples of how to implement FIM strategies in low food access areas?
I mean, some of our grantees are in those areas, so I can put the link to those groups, and then I'm happy if anybody wants to follow up after this to talk through like what their rural area looks like and what might be a similar type of situation. I'm happy to make that connection. I mean, if you're in a rural area, what you know is that they know how to do this. Like this is what they do, is feed people and figure out innovative ways to do it.
Thanks, Mary, and I'll chime in. I went with Mary to some of these organizations in North Carolina. It was very eye-opening for me to see exactly how they're making this work. Anyone else?
I would add that I completely agree. In the interviews I've done and the programs that I've looked at, some of the most creative solutions are coming from rural areas and rural programs. One that specifically sticks out just off the top of my head, they are a GusNIP grantee. This is the Yukon-Kuskokwim Healthcare Corporation. They are dealing with a gigantic geographic region in Alaska and many communities that are not connected by roads. And so that you can imagine that creates incredible logistic challenges. But in general, I would say if someone can share the link to the original Wholesome Wave DAISA field scan report in the chat, I don't know if you have it handy, Brent or Diana, but there are some learnings in that report specifically where we spoke to this issue in particular, and we're lifting up some of the learnings from speaking with rural programs. But I've seen a lot of different, some programs are using mobile markets to drive produce around and deliver it rather than expecting the burden to be on the participant to, travel to a farmer's market or to a grocery store. They're bringing food via mobile market into different communities, or they are partnering with other community services. Maybe they're partnering with a local community center or schools to use those as, to deliver food boxes instead of the onus being on the individual participant to get themselves to a retail location. There are programs that do a box scenario and they deliver them to particular strategic community locations in order to just make the access that much easier. So there's some examples in the original field scan report, and some additional coming out in this BIPOC report, but there's a lot of innovation that I've seen.
Maria Elena, could you quickly repeat the name of the organization, the GusNIP grantee you mentioned?
Sure, it's Yukon-Kuskokwim Healthcare Corporation.
Great,
Health
thank
Corporation,
you.
I believe.
And
Yeah.
just confirming, Brent has linked the produce prescription field scan report in the chat. Brent, you unmuted.
Thank you.
Yeah, this was to Maria Elena's last point. I'm not sure if this person exists, but for anybody who was doing this work before the pandemic and stopped and is now doing this work, One of the things that the pandemic changed is the infrastructure to deliver a food box, both with fresh products and to some pretty remote destinations, and with speed too. And that is in a total different capacity than it was in 2019. It's just grown a lot in the last couple of years, and that's not always the answer. But go to your produce distributors and ask them about it. There are lots, and I don't want to endorse any one particular company here, but there are lots now that because of the investments made by USDA and the rapid response of grocers and plans across the country, there's a lot more capability to do that work now.
Yeah, and for any of the healthcare funders who are supporting community paramedic programs, they've become an important partner in some of this food as medicine delivery and follow-up work.
Great, thanks everyone. I'm gonna go to the next question here from Lisa from the CDC Foundation, and this is for Mary. Do you know if other Blue Cross Blue Shield foundations in other states are supporting food as medicine type programs for CBOs like you are in North Carolina? If CBOs interested in this type of work, any suggestions on who they can reach out to?
I don't know if they are what they're supporting, but I guess I would say always reach out to your Blue Cross Foundation, because certainly it is right there, you know, at the sweet spot of improving health and supporting communities.
Great, thanks.
I've distinctly heard of grants in Kansas City, Minneapolis, California. Those are just some that come to mind.
Thanks. Do we have any other questions, Colin or Tracy? Not sure if I missed any in the chat.
We just got a sort of an anecdote, but also it's a question. So I know Adrian Mundorf, who's from a funder in Cleveland, is sort of an interesting sort of CABG model in terms of bringing together payers, philanthropy, and other providers to sort of do blind bid investments around medically tailored meals. And was curious to know if, I guess I would say for the panelists, and certainly if anybody in chat wants to add if they've had similar experiences, but want to know if there's any other types of examples of models like this.
I don't know what that is. What is that?
Yeah.
You want me
Tracy,
to-
yeah, I was gonna say, oh, are you there, Adrian?
Yeah, I can share a little bit. It's this model that it was a Harvard social economics guy came up with this model, and we're testing it in Cleveland through United Way is this like trusted intermediary. And so Medicaid payers, healthcare providers, and philanthropy are coming together, putting in a bid based on what the value might be for a medically tailored meal intervention. And then nobody knows what we've each put in. And the idea is that we're getting the return on investment based on what we've each put it. Well, philanthropy is doing it for the social good. And that it's sort of a way to test these different social determinant of health models. We picked medically tailored meals as a group, and then you can sort of make the case for public funders like Medicaid or, getting the waivers passed so that you can, scale it up a little bit more. And so I'm just, CAPG stands for something wonky. I can't think of what it's called, but it's this newer model of sort of thinking about social good plus cost savings for providers. And it seemed, we're still in the pilot phase, so we're not seeing exactly whether there is a return on investment with the medically tailored meals here. But anyway, I just was curious if others were doing this in the food as medicine space, because it's kind of a cool way to think about testing these models.
The first I've heard of it in the food as medicine space for at least, man, time flying, around 10 years ago was the first time I heard of that type of model being built out for housing. Because while a health plan may be willing to experiment with a couple $100s a year in food, very few of them are about to buy a house for a patient, right? So it requires, the big investments require a model like that. Also, the ROI equation for most policy frameworks is a 1-year budget cycle. For a housing intervention, you're talking about a payment over the course of a lifetime. And that type of a model allows for a more long-term horizon on the ROI to be fulfilled. So I'm excited to hear about one in Cleveland, and would love to learn more and help advocate for it.
Great,
Diane,
thanks.
I don't
Brent.
see any more questions in the chat box, but maybe we just want to encourage people to come off mute and offer any thoughts, or we have a few minutes left, so.
Yes, please do. If anyone has any thoughts or impressions, please go off mute and feel free to share. And if not, no pressure at all. We do have a 1-pager we'd also like to share after this email that actually just gives a lot of examples of proposals and pitches you might hear from the funding perspective from folks in the food as medicine space. It cuts across, requests for dollars to support the food costs for some of these interventions. Sometimes you'll hear requests for funding to support new digital technologies to support the enrollment into these programs. There's like a whole suite of requests you can get under food as medicine umbrella funding requests. And we've kind of put together, a few of us, some of those examples, and we'll be sure to include that in a follow-up email. And I think that's it from our perspective. I'll hand it back to Tracy and Colin.
All right. Well, thank you. And Colin, I'm gonna unspotlight the speakers here. And I just wanted to thank everybody for showing up. We will definitely provide a recording. We've been recording this, so we'll provide that, as well as the resources that were shared today, and any takeaway points from this call, such as the gaps and barriers that were identified, as well as where the policy opportunities lie, so that you all can have that information, and hopefully that will help you in your grant making. And Colin, any thoughts you want to share as we part ways here today?
No. Well, absolutely. First, I, of course, want to thank our terrific panel of speakers. You all, I thought, had some incredibly salient and insightful points that you made and resources that you shared. I think this is going to be one of the longer resource lists we're going to have post a webinar call in quite some time. And so I think everybody who's here hopefully came away with a lot of information. I know I've even heard of a couple of things that were new to me. Hopefully you did as well, Tracy. But and also to say that certainly this is a space that, as Diana said at the beginning, it is complex. There is a lot of different aspects to it. It's not just produce prescription programs. There's a lot of different aspects to it. And so this is really the way that I'm looking at here at GIH. I know in talking with Tracy with SAFSF, this is probably the first of what's going to probably be a series of programs and calls around this topic and related issues to food as medicine. And certainly a lot of those conversations are going to be bringing in a whole host of different voices, perspectives, aspects, and certainly will include those types of folk and leaders in the field that really represent the communities that we're talking about, especially obviously BIPOC community leaders as well, which are going to be so important to really seeing that this work is done well and done in a very thoughtful and effective manner. So do stay tuned for more programming to come on these issues. I think the only thing I'll mention, Tracy, is that we've talked a little bit here and there about the White House conference that's going to be happening at the end of the month on the 28th. we are already thinking about having a postmortem or a debrief call about that White House conference that both our organizations are going to be co-sponsoring. And so do keep an eye out for that. And certainly if you have any follow-up questions, comments, things that that you didn't get a chance to post in the chat that you want to maybe share, whether it's something that your foundation is doing or a report that didn't get mentioned somehow, because I think between all 4 of our speakers, I think we may have covered anything that's been published in the past 5 years, or give or take. But no, just really glad that you all were able to be here, and we'll hopefully see you in the next call. But Tracy, I will turn it back over to you for final thoughts.
All right, thank you. And a big thanks to Diana with the Rockefeller
Yes.
Foundation for working with us and planning out this whole conversation. And as Colin said, a big thank you to the speakers for everything that's been shared. So look forward for follow-up information from all of us, and we'll keep you all posted as we continue this conversation.